So patients with relapsed refractory multiple myeloma who are triple class exposed have a very poor outcome. And recently published in the New England Journal and also shown at ESCO, it has now become clear that Teclistamab is very effective in these triple class exposed or triple class refractory patients, with an overall response rate of approximately 60%, a median PFS of almost 12 months, and a median duration of response of 18 months. However, the Majestic-1 study that evaluated Teclistamab did not contain a control arm. And because there are therefore no head-to-head comparisons of Teclistamab versus other therapies, I presented at ESCO an indirect treatment comparison to assess the effectiveness of Teclistamab relative to regimens that are currently used in clinical practice. So we compare data from 150 patients treated with Teclistamab at the recommended phase 2 dose with patients that were enrolled in the LocoMMotion study. And the LocoMMotion study enrolled 250 patients in US and in Europe. And in this prospective non-interventional study, patients could be treated with standard of care according to real-life practice. And the inclusion criteria of Majestic-1 and of LocoMMotion were similar, including triple-class exposure, including 3 prior lines of therapy. Patients need to have measurable disease and ECOG status of less than 2, and progressive disease on last line of therapy. So several statistical techniques were used to adjust for imbalances of important baseline characteristics between the both groups, between the patients treated with TEC and the patients enrolled in the LocoMMotion study. So when you look in more detail to the treatments that were given to the patients in the LocoMMotion cohort, then it's very interesting to see that there is no real standard of care for these patients, because there were 90 different regimens offered to these patients with triple class exposed myeloma. Most regimens, however, were triple regimens, 3-drug regimens, and most regimens contained pomalidomide or carfilzomib. So after adjustment, responses observed with Teclistamab were markedly higher than responses in the LocoMMotion study. 63% in the Majestic-1 study versus 27% in the LocoMMotion study. And also the depth of response was much better with Teclistamab than with standard of care in the LocoMMotion study. There was only 1 CR in LocoMMotion and only a few VGPRs in LocoMMotion, while CR rate and VGPR rate was significantly higher with Teclistamab. Also, with Teclistamab, we saw significantly longer overall survival, progression-free survival, and duration of response with Teclistamab compared with real-world physician choice of therapy in the LocoMMotion cohort. Of course, we also have to discuss the limitations of such comparisons. And although there was adjustment for various important baseline characteristics, residual confounding can never be excluded. However, I think the differences are quite large and quite convincing. Although the number of patients that was treated with selinexor and belantamab mafodotin was quite small in the LocoMMotion study, and therefore separate analyses have been performed whereby Teclistamab was compared with patients treated with selinexor or belantamab. And also in these comparisons, although the number of patients was smaller, you see an advantage, a benefit of Teclistamab over these more recently approved drugs for patients with heavily pretreated myeloma. So overall, Teclistamab showed significantly improved effectiveness versus real-world physician's choice of therapy. highlighting its potential as a novel and effective treatment for patients with triple-class exposed relapsed refractory multiple myeloma who received at least 3 prior lines of therapy. And based on the Majestic-1 study, based on this favorable comparison with standard of care, Teclistamab has now been submitted to the FDA and to the EMA in Europe, and hopefully based on all the data that has now been gathered, we will soon be able to treat patients with Teclistamab also outside of clinical trials.